Hello. For today's presentation, we will be focusing on the potential postoperative problem, aspiration, in our patient Thomas John. We will go over definitions, priority concepts, pathophysiology, priority problems, and different assessments and interventions in various situations. Aspiration is the act of inhaling in a foreign object, such as food or liquids, into the lungs and trachea. This happens when the protective reflexes are reduced or depressed by various factors. Protective reflexes can include coughing, sneezing, mucus secretion, and airway constriction. These reflexes are in place to protect the airway from irritants. However, when these reflexes are reduced, foreign objects will enter the lung, causing infections and further complications such as aspiration pneumonia. One of the factors that reduces protective reflexes include post-anesthesia effects from a surgical procedure. This is called postoperative aspiration. The possibility of a patient aspirating in a postoperative setting happens most likely within a 2-hour period. Due to drugs such as long-acting muscle relaxants and general anesthesia, the upper esophageal sphincter remains depressed. Older adults, patients such as Thomas John, are also at a higher risk of having postoperative aspiration. Aspiration may present with symptoms such as tachycardia, dyspnea, central cyanosis, hypertension, hypotension, and potentially death. The priority concept most related to aspiration is gas exchange. Gas exchange is the process which oxygen is transported to cells and carbon dioxide is transported from cells. Gas exchange depends on the functions of the neurological, respiratory, and cardiovascular systems in order to achieve optimal gas exchange. The lungs are responsible for delivering the oxygen to pulmonary capillaries, which is carried by hemoglobin cells, and then carbon dioxide is then carried to the lungs to be exhaled. Some interrelated concepts include perfusion, pain, nutrition, infection, fluid and electrolyte balance, mobility, cognition, tissue integrity, and anxiety.
There are 3 main defenses the body employs in order to protect the airway. During swallowing, there is a flap of tissue called the epiglottis, which covers the trachea to prevent substances from entering the airway. When the epiglottis malfunctions or fails to close off the trachea, coughing is the next line of defense. Coughing is a reflex that occurs in an attempt to clear the airway of an obstruction or foreign substance. During a cough, the patient first takes an inhale. The epiglottis then covers the trachea to compress the air in the lungs, followed by the rapid release of the air in an attempt to force the substance out. The lower esophageal sphincter protects the airway by closing the esophagus off from the stomach. This bundle of muscles prevents stomach acid and gastric contents from escaping the esophagus and potentially entering the trachea. A dysfunction of the lower esophageal sphincter is usually associated with heartburn or GERD. Aspiration occurs when a foreign substance enters the airway of a patient, such as food, liquid, gastric contents, or any other substance. It can lead to chemical pneumonitis, airway obstruction, or bacterial pneumonia. Chemical pneumonitis is usually caused by aspirating a toxic substance that directly damages the lung tissue. It also causes inflammation and pulmonary edema. The resulting inflammation and edema can impede the patient's ability to breathe properly, impacting gas exchange, perfusion, and other systems. An example of chemical pneumonitis would be inhaling gastric secretions. The damage usually resolves spontaneously over time, but it can lead to infection and other complications. Aspiration causes an airway obstruction when the substance either partially or completely occludes the airway. It is usually resolved by airway defense mechanisms like coughing, but it can sometimes require other methods. Aspiration causes bacterial pneumonia when the substance inhaled contains bacteria that infects the tissue in the lungs. The infection can cause the alveoli to become inflamed and fill up with pus and fluid. The alveoli are a vital component of respiration because they're the site of gas exchange. As a result, the infection and inflammation can diminish the ability of the patient to oxygenate the blood and remove carbon dioxide. Risk factors for aspiration include impaired consciousness, impaired respiratory function, neurologic disorders that impact airway control, stroke, dental problems, dementia, esophageal problems like dysphagia and GERD, as well as surgery and more specifically general anesthesia. Signs and symptoms of aspiration include the patient feeling a substance stuck in their throat during or after eating, difficulty swallowing, coughing or wheezing during or after eating, chest discomfort, heartburn, shortness of breath, or fatigue during eating. If these symptoms go unnoticed or addressed, aspiration-related pneumonia can occur. The signs and symptoms of this condition include chest pain, coughing up foul-smelling sputum, coughing up bloody sputum, fatigue, fever, shortness of breath, wheezing, confusion, as well as other symptoms. Complications of aspiration pneumonia can include impaired respiration, scarring of the lungs, respiratory failure, lung abscesses, sepsis, and even death.
Some risk factors for aspiration that are specific to Thomas include his history of GERD, which indicates a malfunctioning lower esophageal sphincter and increases his risk of aspirating gastric content. A history of smoking could also decrease Thomas's ability to clear his airway of obstructions. With Thomas's advanced age, this can reduce his gag reflex and weaken his accessory muscles, which would weaken his cough and decrease his innate protective mechanisms against aspiration. During his pre-op assessment, it indicated that Thomas had wheezes during exhalation and shortness of breath on exertion. The wheezing could be a sign of a narrowed airway, and shortness of breath decreases his capacity to clear his lungs. He also has a smoker's cough, which could cover the symptoms of aspiration. During the surgery, Thomas was under general anesthesia, thus unable to protect his own airway while being sedated. On post-op day 0, his risk factors for aspirations include decreased lung sounds to the bases, which could indicate air or fluid around the lungs, and adventitious lung sounds on chest auscultation and reported nausea that could cause vomiting, which could result in aspiration. In post-op day 5, the positioning and decreased mobility reduces Thomas's ability to cough to clear his lungs. Additionally, the reported increased respiratory rate of 23 breaths per minute and 8 out of 10 incisional pain can limit his lung capacity, which is vital for using coughing as a mechanism to protect the airway. Thomas is also on opioids for pain management, which puts him at an increased risk for sedation and respiratory depression.
Postoperative aspiration is a priority problem for our patient because it can lead to aspiration pneumonia. Postoperatively, sedation, lack of mobility, and opioid diminish normal airway defenses, putting Thomas at an increased risk of aspiration. Pulmonary aspiration under anesthesia is not uncommon, approximately 1 in 3,000 general anesthesia procedure. Aspiration can lead to pneumonia, which, if left untreated, can cause significant damage and lead to systemic problems, like pulmonary edema that impairs gas exchange, sepsis, and eventually death. If aspiration pneumonia occurs, the patient can develop respiratory distress, which can be life-threatening or delay wound healing due to hypoxia. Chemical aspiration pneumonitis related to gastric secretions can cause chemical injuries to the lungs that can be lifelong and lead to further complications like recurrent pneumonia. Swallowing assessment. Assess swallowing activity and function by X-ray and recording what happens when the patient swallows, looking for inadequate coordination of laryngeal movements and orofacial muscle activities in swallowing. It is often related to anesthesia, opioid, and sedative use during surgery, or patient with long-term intubation or swallowing dysfunction. Focus respiratory system assessment. Inspect patient's use of accessory muscles and work of breathing, skin color of lips and face, auscultate lungs looking for increased respiratory rate and abnormal breath sounds, gagging, choking, and coughing, any adventitious lung sounds, increased demand for oxygen saturation. Assess for clinical signs and symptoms for hypoxia. Assess for decrease in SpO2, confusion, decreased level of consciousness, dizziness, increased heart rate, decreased urine output, decreased bowel sounds, shortness of breath, sweating, changes in skin color. Focus gastrointestinal system assessment. Inspect patient's abdomen, contour, auscultate, and palpate 4 quadrants of abdomen, looking for abnormal bowel sounds related to intestinal obstruction, paralytic ileus, ascites, and peritonitis. Complaint of nausea or signs of vomiting. On Operative day 0, Thomas has slightly distended abdomen with no bowel sound in 4 quadrants, no flatus. Although this is normal for post-operative day 0, it will be important to continue to monitor as these conditions may indicate intestinal obstruction contributing to stomach contents flowing back into the esophagus, and dysphagia can cause food or liquid to remain in the esophagus after swallowing. If these contents are inhaled and moved into the lungs, it can lead to aspiration pneumonia.
To monitor and prevent postoperative aspiration, we have divided our interventions into 4 categories. Number 1, compensation for depressed reflexes. Aspiration can occur if the patient cannot adequately coordinate protective glottic, laryngeal, and cough reflexes. This hazard is increased if the patient has a distended abdomen and is supine. Place the patient in a semi-Fowler position with the head of the bed 30 to 45 degrees unless contraindicated. This position improves oxygenation and increases oxygen saturation. A swallowing assessment with a speech therapist for patients with known swallowing dysfunction or recently extubated. Suggestion of a soft diet with encouragement to take small bites and instruct the patient to keep their chin tucked and their head turned with repeated swallowing. Number 2, assessing feeding tube placement for patients with nasogastric and gastrostomy tubes. Confirm placement of enteral tubes and administration of tube feedings to make sure feeding tubes are positioned correctly in the stomach and to prevent inadvertent tracheal malposition. A displaced tube may mistakenly deliver tube feeding into the airway. Initially, an X-ray is confirmed tube placement. Methods used in combination is recommended. Measurement of tube length is measured every shift and compared to original measurement. Gastric, intestinal, and lung aspirate all have different color, volume, and pH levels. Number 3, provide oral care before and after each meal to remove residual bacteria. Number 4, pharmacological preventative measures. Notify the physician and administer antiemetics such as Zofran and Reglan to stimulate GI tract motility, and anti-ulcers such as Pantaloc to decrease gastric secretions. Now we will identify 4 priority interventions for post-operative aspiration if it were to happen. Number 1, administer oxygen therapy to supplement for low oxygen saturation level and bronchodilators as ordered by the physician. Number 2, maintain the patient in a Fowler or semi-Fowler's position before and after meals. If the patient vomits, protect their airway by sitting them up or turning them to the side. Number 3, collaborate with speech-language pathologists to perform a dysphagia assessment to reassess diet plan and MD for further diagnostic interventions such as prophylactic antibiotics, CXR monitoring, or the need for bronchoscopy. Number 4, apply suctioning with proper use of a yanker to remove residual content in the patient's mouth and to prevent further aspiration of content. If the patient is in respiratory distress, ask for assistance from a respiratory therapist. Encourage deep breathing and cough exercises. That concludes our presentation. Thank you for listening.